Good evening. Welcome to the MyCP webinar series. My name is Paul Gross. I don't have my camera on, so you can't see me, but I'm going to turn it on. Nothing seems to be working. Welcome to the MyCP webinar series. This is our set of community-focused presentations where we share the outcomes of our research for the benefit and engagement of the CP community. Tonight, I'm excited to be able to have Dr. Liz Boyer talk about the consequences of falls for people with cerebral palsy. She's been conducting a study that really spans a broad age range, and we collaborated with her to collect data on adults, but she's going to share results from her full data set. So I'm going to do a quick introduction of the CP Research Network and then turn the microphone and slides over to Dr. Boyer, and then we'll open it up for Q&A. So the Cerebral Palsy Research Network, our mission is to optimize the lifelong health and wellness of people with CP and their families. And we do this through high quality research, through educational programs, and through wellness programs. We've made a lot of progress since we were founded in 2015. My business partner, Michelle Schusterman, created the CP Toolkit to really provide evidence-based information in lay language to people who had gotten a diagnosis of CP. That was released in 2015. We've served up more than 4,600 copies of that on our website and distributed through hospitals. And then we went on to release a well-being guide for caregivers, because as I said, we're really focused on the person with CP, but also caregivers. And then we went on to translate that CP toolkit into Spanish and Portuguese in 2017. In 2020, we launched My Cerebral Palsy, or MyCP, which is a portal that gives you personalized web information. I'm going to talk about that a little bit more in a moment. On the research front, we were really founded to build a registry in the United States for people with CP. A registry is a database that has certain numbers of characteristics of people with CP. And our clinical registry, i.e. one in where data is collected when people come into a hospital or clinic setting, was launched in March of 2016 and has over 7,500 subjects in it, patients in it. And then a community registry, which is really intended to capture the lived experience and patient-reported outcomes, and that was launched in 2019 and has more than 1,500 participants in it. One of the first things we did, given that we were founded by two parents of children with CP, was we created a patient-centered research agenda for cerebral palsy. That effort was called Research CP. We involved over 200 people from the community in the process. We published the results of that in 2018, and that really drives our research agenda. We really want to solve problems that are meaningful to the community. We've gone on to have some significant public and private funding milestones, both for registry infrastructure, support of capturing data about epilepsy, genetics, dystonia, and more recently, we've gotten some funding to support our adult well-being studies. We also have 4 quality improvement initiatives. Quality improvement is another way to improve outcomes that's different than doing research to generate evidence, but it has a much sort of faster effect on the overall system for care. And so we've got 4 of those going on in the network. And then we're producing academically the information from our studies in the form of publications, of which we've had 8 publications in journals. We have had about 27 academic presentations, and we have 5 more scripts that are manuscripts that are either just been submitted or in the process of being submitted. So we try to produce that evidence and then roll our learning from that back into our practice. And then our wellness programs, we really have 2 at this stage. We have a virtual wellness program called MyCP Fitness. There's some people that have joined tonight that I know participate in that regularly. That's 2 days a week of free virtual fitness, led by a woman who's got CP and is a CrossFit trainer and really can get your heart rate up, which is good for everyone's health. And then we also partner with the National Center for Health, Physical Activity, and Disability to bring the mentor program to the CP community, and Mentor is a mindfulness, exercise, and nutrition program. So it's really a marvelous 8-week free program that we offer to the community. So we are a not-for-profit, and we're really just bringing together institutions that care for people with CP, the clinicians, therapists, researchers that are there, along together with patient advocates and members of the community, all to just improve outcomes for people with CP. Physically, we have a data coordinating center that's hosted at the University of Pittsburgh in what's called their Epidemiology Data Center. And there we have these 2 registries, our clinical registry and our community registry. And then we run this series of education and well-being programs. So I mentioned MyCP. This is a free personalized web portal that is built into CPRN.org, built into our website for the extended community. It offers participation in our community registry through surveys that you can take from your phone or from your PC. It allows you to discuss research on a private forum. We have clinicians engaged on that forum, providing evidence about various things that people are inquiring about. We also provide personalized web information. So based on information you give us, we share with you what is the most important information on our website to consume. And it's also how you get access to our wellness programs. So because I've talked about these registries, which are kind of infrastructure for conducting research, I want to share 2 data points across the 2 different registries, just to give you an idea. So there's a very important classification system used in CP called Gross Motor Function Classification System. And this is a 1 through 5 rating that is a assessment of, assessment's not the right word, but is a classification of how you move around in the community. And so level 1 through 3 move around independently, maybe with a walker, and 4s and 5s use a wheelchair to get around in the community. So if you look at this back in November 2021, about a year ago, when we had about 5,200 patients in the registry, you can see the distribution of the different GMFCS levels that are seen in our in the hospitals that contribute data to our registry. And then on the right-hand side, you see the age distribution. And what you can see there is more than 20% of the people in our registry are adults. But that's our clinical registry. So some of our sites are lifespan centers, some of our sites are just pediatric in focus. If you take a look at the 2 charts on the bottom, on the left, you see that gross motor function classification system. You see a very different distribution because this is who we're finding on the web and engaging. And then if you look on the right, you see the age distribution, and you see we have far more, as a percentage, far more adults engaged. And that's a function of what we can connect with people online. So that really summarizes the programs of the CP Research Network. We're very focused on community engagement. This is a shot of the group that assembled in Chicago when we did Research CP. On the right, you see our investigators all gathering together in Michigan for our annual meeting. At the bottom, you see our resources for education, and then our health and well-being programs. So we are spread across North America. The green pins represent sites that are collecting data in the registry. The yellow pins are working on the technology aspects of that. The red pins are working through some of the compliance, like institutional review board approvals for doing the registry as research. And the blue pins are sites that have raised their hand and said, we want to join the network, but they actually haven't gone through all the process to be onboarded as of yet. So it's approximately 30 sites at this stage, and expected to continue to grow. So the last thing I'll share before I turn it over to Dr. Boyer is our research pipeline. We do, exist to generate more evidence that will be used to improve outcomes in CP. And so on the left-hand side, you see the wide end of our funnel where we generate ideas, and these can be community members that are generating ideas. I've been working on this SDR effects study for a couple of years. We're about to submit it again to NIH. So ideas are generated. They go through an approval process. They get implemented in the registry or in sites. And then we produce manuscripts from from the evidence, and if there's indicated change in practice, we roll that back into the way we collect data. The blue ovals are the studies that we have. You see the consequences of falls is a study that's finished study execution and is in the manuscript generation phase. And then the orange ones are our QI projects. So with that, I'm excited to turn it over to Dr. Liz Boyer, who's a clinical scientist at Gillette Children's Hospital. And she's also an adjunct assistant professor at the University of Minnesota in their Department of Orthopedic Surgery. And she got her PhD in kinesiology with an emphasis on biomechanics and motor control. I turn it over to you, Liz. Let me stop sharing so you can have control. All right.
All right. So thank you, Paul, for the introduction. Thanks everyone for being here. I really appreciate the support, and I'm excited to tell you about our preliminary results of our consequences of falls study. And by no means are these final, but we are doing the preliminary analysis before we start our manuscript writing. I want to begin by acknowledging our funding, which came through our foundation, and my co-investigator, Linda Kroc, coordinator, Marissa, and many other individuals who have helped in the planning stage of this and helping me learn more about falls, and those who are now on the team as patient partners to help in interpreting the data and disseminating it. Of course, thank you to the research CPRN for helping with the recruitment, and all of our participants for taking these surveys and helping us understand more about falls. Full disclosure, the motivation for this study really came from reviews on a grant that I submitted. The review panel felt that falls were not complicated in the CP population, and that those in GMSDS level 1 and 2 who have higher motor function might not experience as many falls. While I disagreed with this, it did give me pause to reflect more critically on the level of evidence in the literature and where the gaps are. In regards to fall frequency, there's not many studies in children that have reported falls. It's more anecdotally known that this is a concern for families. This one study here reported 27% in an average of 40 days, but this isn't real life. This is children admitted for inpatient rehab. And so these were falls within the hospital. And it also included individuals GMSDS level 1 through 4. In a study that was retrospective, so we looked back at data collected clinically from patients who've gone through the gait lab at Gillette. So among over 1,000 of those individuals, about 2/3 reported falling at least monthly. In adults, there's a little more literature, but again, few prospective studies that track falls. Among ambulatory individuals, rates of falls reported, range from 50 to almost 100% of the sample. The consequences of these falls, I think most often we think of injuries. We have a wide span of estimates here too, from no falls resulting in injuries to maybe 2/3 of them. So more clarity is needed here. And while interview studies most often report some of these concerns like embarrassment, frustration, and activity avoidance, loss of independence, these outcomes have not been systematically studied in larger samples. So a lot of work to do there, in addition to trying to increase our sample size, because many of the studies try to summarize results across large age ranges of either kids or large age ranges of adults and group GMSDS levels together. But data from our lab suggests that it's really kind of those GMSDS level 2s that most often fall. And so we highly suspect there's these differences that need to be recognized and treated separately. In a more recent study, adults have reported that it's more embarrassing and scarier to fall with increasing age. So we have to recognize those age differences and report likewise. Many of the studies that exist, interviews are great in their ability to report concerns and provide greater detail, but it doesn't help us objectify how prevalent or to what extent this problem is. So we need more quantitative studies to do that. Therefore, the existing knowledge gaps is this lack of understanding about what is the true physical and psychological consequences of falls in adults and children with CP, and which age and GMFCS level strata tends to bear the burden of these falls. Our study purposes were to start to try to close some of those gaps. We really wanted to focus on reporting the frequency of falls, fall characteristics, injuries, and start looking objectively at those psychological consequences of falls. And we wanted to do this for specific age and GMFCS level subgroups. To do this, we recruited individuals diagnosed with cerebral palsy in GMFCS level 1 through 3. As Paul explained, they are typically independent ambulators. Children, their parents reported or self-reported or proxy reported for the child, but we also asked parents to consult with their child for input as appropriate. Adults could have been 18 to 89 years old, and all had to be able to read in English. Recruitment was primarily done through email sent to our Gillette patients, both children and adults. But secondarily, we also sent print flyers in clinics and tried some recruitment on Gillette Facebook groups, as well as obviously the MyCP community registry. We asked individuals to complete online surveys that encapsulated some of the physical domain outcomes and psychological outcomes, which I will show you more of those surveys later. For our purposes, we defined a fall as unintentionally coming to rest on the ground, floor, or other lower level, with or without injury. We asked people to recall how often they fell over 1 month and 1 year, as well as recall how many times they've had a serious injury. And serious injuries were defined as broken bones, sprains, stitches, joint dislocations, or concussion. We were fortunate to have 382 participants complete at least one of the surveys. Of course, we had some missing data. The majority were adults, including 63 adults from the CPRN community registry. And here's a further breakdown of which age and GMFCS level group these individuals fell in. So along the rows are your GMFCS level, and then age are your column, or the columns are your age. The squares that are darker blue represent smaller sample sizes. So we did our best to try to recruit from these, but we still struggled to get larger sample sizes. And so this really means that we just have less confidence when we try to summarize, and represent these groups. We have less confidence that we're really capturing what the true population might be based on these smaller sample sizes of 8 or 14, for instance. Especially those middle adulthood, we are missing, or we don't have very large samples. We had approximately equal representation across gender. A little over a third were self-reported as hemiplegic or monoplegic, and not quite a third reported at least mild cognitive impairment. To make sure that we're all on the same page, I want to briefly describe a summary statistic called the median. And this helps us report kind of the central tendency in a distribution of data. So median is the middle number, and it's helpful as compared to reporting the average, for instance, when we have data that might look like this graph below, where we have this skew or this kind of trailing tail on the right. And so if we reported the average would be biased towards that tail, whereas the median is not. So for instance, if we had 5 people and we asked them how frequently they fell, and they gave these responses, to calculate the median, we would have to sort them and then identify that middle number. So the median falls for this group was 1. If instead we calculated the average, which is just summing up those values and dividing by 5, which is the number of observations, the number of people, we would get a much different answer of almost 6. And so as you'll see on the next slide here, we're going to be reporting the median for the frequency of falls over the past month. So along the y-axis is the monthly falls that people reported, and along the x-axis, horizontal axis, are our 5 age groups. And throughout this presentation, I'll use blue, pink, and purple to represent GMFCS level 1, 2, and 3. Every individual dot you see here is a person, and we have a lot of outliers, which kind of squishes our data together along that y-axis. So just for viewing purposes, I'm going to zoom in. Most people reported 20 or fewer falls. So you can see that now here as we take this zoomed in approach. The larger circles are those median values for that group. So right here, this is the 5 to 12-year-olds who are GMFCS level 2. And we can see that they reported falling in the past month of about 5 times, which is over twice as often as their other peers in GMFCS level 1 and 2. We can expand that and look at how this differs across the age range that we were able to capture. And if we wanted kind of visualize trends with age, we can see that at least for GMFCS level 2, there does seem to be some decrease, of course, with the caveat that we have smaller sample sizes for the adults. If you don't like viewing these data in this scatter plot form, the data are also plotted here in a tabular form, where I've color-coded larger values as darker blue. And so again, it's clear that GMFCS level 2 tends to fall more frequently. When asking to recall falls over the past 12 months or entire year, again, we have a lot of outliers, may be correct or just maybe difficulty in estimating that. Zooming in, most individuals reported falling 60 or fewer times per year. And we can see similar trends where those in GMFCS level 2 tended to fall more frequently, and it does seem to taper off as children enter into adulthood. We can look at these data differently though, even. So we can say, of the population of this subgroup, how many fell at least 1 time per month or at least 1 time per year? So those data are plotted here. So proportion of population is on the y-axis. And regardless of age or GMFCS level, almost everyone, 40% or more of the population reported at least 1 fall in the last month. And over the past year, as we might expect, it increases. And especially among GMFCS level 2, in the yearly falls, they report, almost 80% or more have reported at least 1 fall. To help you contextualize this, we can look at individuals without identified disabilities from the general population who are 65 or older in the United States. And approximately 28% of those individuals fall at least once a year. So that means our individuals across GMFCS level, across age, tend to fall 2 to 3 times more than this older adult population, which they are often the focus of many of the fall prevention campaigns and funding. So I think we have a great argument here that falls are common, falls are of concern. And another way to justify this is looking at serious injuries. And you'll see here the percentage of individuals who've had at least 1 serious injury on the y-axis increases drastically across age, such that when you're 51 or older, less than 10% or maybe 10% have not had a serious injury at some point in their life. While there's not major GMFCS level differences for the majority of these age groups, for this younger age range, it does seem that this is a true difference. where they're probably about twice as likely to have experienced a serious fall before their 12th birthday. And recall, we did have pretty large sample sizes for these smaller or these younger age groups. So this is probably a true difference between GMFCS levels. The type of these serious injuries was most often some type of fall that resulted in stitches on the face or head for both adults or child, followed closely, by concussions or a sprained ankle or sprained leg. Most often these falls occurred during ambulation, whether it was walking, running, or stairs. Averaged across the entire group of people who responded, about 3/4 of falls occurred during ambulation. Maybe some differences there between GMFCS level 3 and the others, which data will support that later too, that maybe not as many of their falls occur during walking. As far as assistance, whether it's holding a handrail or holding someone's hand or using an assistive device, this was less common for use when someone reported a falls, but the differences between GMFCS levels follow what we would expect based on mobility needs. The direction of fall most often was forward. Less frequently was backwards, followed closely behind by falling sideways, left or right. And finally, the least common direction was falling down or legs buckling underneath you. Here, there does seem to be some differences between GMFCS levels, again, supporting what I said before, is that these individuals may be more likely to have their legs buckle straight down or just have different characteristics of falls, right? The direction of falls. Most often individuals were reporting that they were wearing some type of footwear for these falls, and we see maybe an increasing trend across age. And we obviously can see the opposite trend across age for the other types of footwear or lack thereof. And not too many obvious differences between GMFCS levels here, maybe a little bit for barefoot. Among the 4 possible causes that we identified, uneven surfaces were most often attributed to falls. Fatigue was next. It was most common in about 32% of individuals, and more so in the GMFCS level 3s in that purple color. And then about 1 out of 5 falls seem to be associated with slippery surfaces or being bumped. So asking individuals then about what is their concern about falling during different activities. We use the Short Falls Efficacy Scale, which has 7 different items shown here. And they are asked to rate it from no concern at all to very concerned. And those values were summed together to get a score where higher values, higher scores represent more concern about falling. And what's pretty clear from these data is that even though GMFCS level 2 tended to fall more often, in every group except those middle adulthood, we see this clear trend towards GMFCS level 3 reporting the highest concern about falling. And the data presented differently here in tabular form, and then again averaged across the entire sample, we see a score of about 14. And again, to try to contextualize this, we can compare that to a score of about 12 from the general population of individuals 70 or above. The activities that most often elicit this concern about falls were uneven surfaces or going up and down stairs, slopes, and bathing. Furthermore, we can look at avoidance of these behaviors or avoidance of these activities by asking individuals, do you avoid performing this activity due to your concern about falling? ranging from no, never to yes, often. So again, we sum those scores, and larger values represent more avoidance. For the most part, across GMSCS level, we see similar trends as we saw before about the concern about falling, though we see the overall scores have shifted down. With the median score being 9, which generally seems pretty low, not much avoidance of behavior. However, compared to the general population of individuals 70 or older, their median score was 7. And so again, we have elevated concern and elevated avoidance of activities due to concern about falling. Some of the activities that they most often avoid is going up and down slopes, reaching above your head or down to the ground. And for GMSCS level 3, they avoid stairs more often. As far as the psychological consequences of falls, there's a scale called Consequences of Falls Damage to Identity, and it asks 6 items such as the feelings of embarrassment, foolish, causing a nuisance, losing my confidence, being in pain, and having difficulty getting up. And you rate it from strongly disagree to strongly agree, sum those scores. And higher scores represent more negative psychological impact of falls. And what we can see here is that we don't have much effect of GMSCS level. So the effect of falls is relatively high regardless of GMSCS level. But there might be this slight trend of increase with age. And I can view those data again in tabular form. A mean score, so mean, not median score of 16 is relatively high and again higher than the general population. As far as how many people identified, yes, I wish I fell less, it was 88% across the entire sample. And we can see the distribution or the differences between the different age and GMSCS level strata. Again, with GMSCS level 2 and some 3s having the highest level. Well, we don't have time today. We did ask for kind of open-ended responses about how you've adapted to falls and providing another clarification or input on how we can make falls more psychologically and physically safe and have these conversations. And so in the future, we'll be analyzing some of those data. In summary, almost everyone wishes they fell less. Most often these falls are forward during ambulation, wearing shoes and on uneven surfaces. Stitches to the head or face is the most common type of medical care sought after falls. Individuals in GMSCS level 2 fall most often, at least for kids, though it's the GMSCS level 3s who report the greatest concern about falling. There is some avoidance behaviors due to these concerns about falling, and the negative psychological impact of falls, at least falls that it would occur in public, is high, and it seems consistently high across GMSCS level and age groups. This study wasn't perfect. We learned a lot from it, and moving forward, there are things we would want to do differently. So some of the things we are well aware of and appreciate the feedback that we've received from participants is that there is recall bias, of course, and this might affect some of the outcomes more than others. And this is a concern with any type of retrospective study. So ideally in the future, we do a prospective study and we try to passively measure things, maybe with wearable devices to track falls. Try to do live monitoring or tracking of some of those embarrassment or pain or other outcomes using ecological momentary assessment methods or other validated methods and surveys. We had small sample sizes, at least for some of those adults in GMSCS levels, which limits our generalizability. Of course, we had unmeasured covariates. especially of importance is the amount of physical activity. If you choose to be more sedentary, you have less likelihood of falling. We also, I heard feedback from others saying that if someone's multitasking or dual tasking while they're walking, they're more likely to fall. If they recently or currently are sick, spasms, dystonia, so forth, all could be additional causes of falls. And sometimes maybe people don't know what causes their falls, and we need to ask those questions. For some of the other outcomes, like maybe how people are concerned about falls, or if they avoid activities, that might be influenced by how others treat them or put limits on their abilities. So that has been a fun conversation as we try to think about and interpret our results and plan future studies on the topic. Clearly, we need more clarity in our questions and more CP-specific validated falls questionnaires. I also want and hope that these data will provide some educational opportunities for many people, including the patients, their families, and the whole care team, not just physicians, but the community therapists, the teachers, and so forth. Obviously, research is helpful for us as we design our future studies. And then the public, and we really hope that there's a lot of concern raised for universal design and accessibility. And so we'd love to see some changes in that area. These data can help us anticipate age and GMFCS specific needs. We also clearly could have an argument for the need of clinically tracking falls and their consequences. And especially consider the possibility that psychological counseling referrals may need to be made for those who need it. And most of all, I would love to be able to have encourage conversation on this topic and build trust and learn. So we have work to do in that area, and working with the patient partners on this project has opened my eyes to many of those things. So with that, thank you for listening, and reach out if you have questions, and I'm looking forward to hopefully a very fruitful conversation now.
Great, thank you so much. Okay, let me see. If you turn off your share, we will open it up to questions. I'm going to grab a question out of the that's sitting in the chat, and then I'll just open up for people. So if people can use the raise hand capability, that'll help me be a little more egalitarian in sorting this out. But so one question was, are you looking at people in wheelchairs and falling with wheelchair transfer at all, or do you know of any research going on in that area?
I did not. I do know that that was a concern or question brought up. I guess part of the reason we focus mostly on ambulatory individuals was driven by that study out of the GATE lab that I did, where it said most individuals in GMFCS level 4 did not indicate that they fell. And so I was trying to target individuals who are more likely to fall. I agree, we are not capturing everyone. So definitely an opportunity. So thank you, Susan, for sharing that.
Okay, I'm going to go back and forth. So June Kales, want to ask your question?
Yeah, thanks. These are great slides, very clear, very impressive. Under causes of falls, I wondered why spasm or spasticity was not listed. I've always referred to the cause as in CP is like having a personal earthquake, it just comes out of the blue, it's unexpected, and wow. So I wonder about that, and if you could comment about why that wasn't a cause listed. And also, a lot of my peers with and without CP now comment on the fact that we have spent our entire lives trying to not fall. So in the current fall prevention literature that's targeted at the older population, doesn't feel sometimes all that relevant for us. So 2 issues.
Yeah, thanks, June. I will say that like kind of the template I used to start structuring this survey, like causes for falls, was based on another survey called the History of Falls. And so they listed different like environmental factors and some internal factors, but I used that as that template to identify variables without trying to overwhelm people. Because if you go to the other fall literature from like older adults, there can be a big laundry list of possible causes like medications and recent sickness and illness and many things. And so I didn't want to overcomplicate it. It is part of it, but I've heard this comment more frequently. So it's absolutely a limitation, and we should have measured tone, spasticity, dystonia, spasm, something for sure. And so in the next iteration, I think we have to measure that. So that's the response there. And then as far as your second response, yep, about the existing kind of older adults, general population not being relevant. I've heard that comment more than once. I believe it. I don't have a better answer for whether some of their data are or aren't relevant, or some of their interventions that they use to try to decrease falls, whether that would also be relevant in the CP population. I don't know, but those are things that I hope to find out in future studies.
Okay, thank you. Amber, I see your note, and I'm just going to say type your question into the chat and I'll ask it. But Paul, you have your hand up.
Thanks, Paul. Wondering about the consideration about people who are more ambulatory, who participate in activities where falls could be more prevalent. Is that an additional scale that you want to measure? I'm just brainstorming here. Yeah, because I live a fairly active life and ride motorcycles, bicycles, things like that. So I'm going to fall more often, just like anybody else.
Yes, I agree. This was a concern. Maybe it was you who brought it up in one of the replies that I had. But yes, obviously, how physically active you are, how many steps you take, the level of challenge of physical activities that you engage with could definitely increase your risk for falls. And therefore, it may seem like you're falling more, even though you may have greater skills or ability, if that makes sense. So it definitely could be one of those covariates that we aren't measuring. And in the future, I think we should try to objectively measure that, whether it's self-report or whether it's some type of activity monitor that can accurately check or capture how active people are.
Sounds
Great
good.
question.
And I really like the idea about wearables. I've talked to several people in the community. I work for Microsoft. I think bringing wearables into these studies and giving direct feedback is going to be essential as we move forward with these treatment outcomes.
Yes, I have a professor from where I went to school who does a lot with activity monitoring. So on my long list of future studies is to reach out to him and see if we can collaborate to do some validation in CP.
Great. I'm going to go to the board before I come back to you, Amber. So Margie McWee said another covariate is that many people with CP have cerebral visual impairments, which impact their visual processing and integration with gross motor function. Any thoughts, comments on that other than yes?
No, again, I agree. I know that this is an issue from the literature on CP, and then I know it's also been identified as a potential risk factor in the general older adult fall literature. So it's something that I'd like to do. I think we could come up with a huge list of some of these potential impairments that could reasonably cause some of the falls. So lots of variables means we have to have large sample sizes, which I hope we can do in multi-center studies, but baby steps, we will get there.
Great. I will plant a seed that one of the things we can do is link the patient-reported studies to the clinical registry. Yeah, so it creates an opportunity to have more data to look at things. So I'll plant that seed, because if you want to write a grant to do that, that would be fine with me. Turn it over to you, Amber.
Are there any current apps that can monitor falls that you know of, just in general, not one for specifically for CP, although that would be helpful in the future? And then the other part of, or another question I had is there any long-term data on, because people with CP have more falls over a lifetime, not just serious injury, but just the trauma in general, or the jarring, how that affects the body, because we all know you have muscle memory, it all is in there somewhere, and how that affects future falls. I often wonder, myself, how that all goes together.
Yeah, your first comment, I am aware that the Apple Watches, at least certain generations, more recent generations, have a fall monitor, fall detection function on them. I read a little bit, oh, I see, yep, Susan wrote that too. I read a little bit of how they, like their big data set that they tried to use to create that. And it sounds like they focused, I mean, there is some with older adults, but a lot of it was also like high impact sports related falls. So they specifically commented like falling from a mountain bike. And so I have no clue how well that would be at capturing falls in this population. So I would love to try to work with them and see if we can see how accurate it is. In that searching, I know I looked and there's other wrist-worn wearables that do measure falls as well. I don't know enough about the commercial products though to see how well they work. But I think I'd probably start with Apple Watches first. And then your second concern, oh, like minor falls.
Like
and falls over
I guess the cumulative trauma, even if it's just a minor fall versus what we consider a serious fall, how that affects the body in general over time, and also possibly affects multiple falls, because that's held within the body forever. I mean, just like everything else is. So I just was wondering, like, what your thoughts are on that. Not that you have an answer necessarily for it, but I know as I'm getting older, my body is not as forgiving. I mean, when you're little or young and you fall with CP, it seems like no big deal. Now the slightest fall for me, because I don't have very much padding, and it's like, oh, this hurts, even though I'm taller, but not much taller. So but it really hurts a lot more as I'm getting older.
I would love to do those longitudinal studies so that we can say, what are those effects? And like you kind of said, what are the outcomes that we should be measuring to make those statements or comments? Is it balance? Is it, I don't know, pain? Is it psychological, right? Does that cumulative falls result in extra anxiety or concern, right? I know that some of our conversation with our patient partners have brought up that right away, people may not have that immediate response to the trauma of the fall, and it might be the next day or after where people experience that anxiety or those panic attacks related to that. So I think a lot of work to be done in both those physical as well as psychological outcomes.
Okay,
I wish I had a better
You're up.
answer, Amber.
Thank you.
Go ahead, Chris. You're muted.
Yeah,
There you
no,
go.
I got it. I got it. Okay. My question was, over Thanksgiving, I was at a friend's house, and I was trying to get from his basement up to his kitchen on stairs, and for whatever reason, I ended up getting a little bit scared of falling. Now, it was just a normal stairway, but I didn't have a stable surface on the strong side. I have mild cerebral palsy, but my right side is my dominant side. I guess I was a little scared of falling. And then I had trouble just getting up the stairs, and it was a little bit frustrating because all of a sudden my hips didn't want to push off so that I can step. Is that more psychological, or is that a physical thing that I need to work on?
I'm not a clinician, so I can't provide any advice in that regard. But I know that you're right, your psychological concern can have an impact on your physical function. So I can't provide more information than that, besides it probably could be addressed mostly psychologically. Mhm.
Okay, thank you.
All right, Duncan, you get the last question, although I had a last word question that I'm going to wrap up with when I thank Liz, but we gotta try and land the plane right on the hour. Go ahead.
More two observations rather than questions, because this requires more. Number one is June talked earlier about our fall prevention information, but in all my PT sessions, I've never had a physical therapist teaching me how to fall. And yet in the martial arts, if you take a martial arts course, that is your very first lesson, how to fall, how to avoid injury. Secondly, in youth sports and adult sports, we see an awful lot of concussion protocol rules and regs. I just feel we need to have some concussion protocol regarding our population for immediate assessment of the concussion impact.
All right, well, I'm going to take those observations. I am going to thank you, Dr. Boyer, so much that you presented a lot of data, but the tools you used to present them and your language around it was exceptionally clear. It was really useful. Excited to have you studying this area. I have one final question for you, which is, are you going to take the data you developed and resubmit for that award, or are you just moving on to other areas of research?
I will use it for a related application. I will change what we're proposing, but yes, absolutely use this as justification for this is a problem, we need to study it.
Well, thank you once again. Thanks for leveraging the CP Research Network to get some of your research done. We appreciate your time tonight. Thank you.
Likewise, thank you all.
Good night, everyone.